to discuss a few. And I would want uh, all of you to participate in the discussion, and let's find out the solutions for uh, some of these issues. This is a patient who first consulted me in 2006. She had that at the age of 24, 2006, age 24. She had 3 cesarean sections, 2008, 2012, 2013, and has 1 boy and 2 girls. Afterwards, she practiced contraception. She had copper T for some time. And then in 2020, in an ultrasound, it was found that she had an adnexal cyst. At that time, she was 38 years of age, but that cyst was comparatively small, about 48 into 36 millimeter. It was said about at that time that most likely it's a dermoid cyst. So she was kept under observation. And in December, she came, and this year, she came, and her cyst was at that time 38 into 31 millimeters, and another loculus was 35 into 30 millimeters. And the diagnosis was likely dermoid plus a hydrosalpinx. In the meantime, she had actually an ectopic pregnancy, which was in February 21, and the lab surgery was carried out, and in that right tube was removed because it was a right tube pregnancy. Even at that time, of course, that cyst was noted, but it was left behind. On 22nd of December, she had lab surgery, and the cyst, that dermoid cyst, reported dermoid cyst, that was removed. It was rather firm, rather hard, and an endobag was used to remove it. The cyst was, or the tumor was broken up within that endobag and removed through the endoscopic portal. The histopathology report of this patient is papillary thyroid carcinoma arising in teratoma. And now she is, the age of the patient at this point is how much? 17, 41, 41, right? So essentially, this is a case of a 41-year-old woman who had a cyst or an adnexal tumor for the last 3 years, was kept under observation because the diagnosis, provisional diagnosis on ultrasound, was dermoid cyst, and the size sometimes was reported to be a little larger and sometimes a little less. And now she had complained, actually, she had come with a complaint of pain, lower abdomen, left side, on which side the cyst was. And that's why it was removed. So this is the case, how to go about it. I would ask all the prospective participants on the net to make up the workup of this patient and how to proceed about it. We'll talk about it a little later. Second case. Which is a common one these days. 26 years. This is the tragedy of it. 26 years, para 2 plus 0. First cesarean section in 2018, twins, 2 baby girls were delivered. One had a neonatal death, and 1 is alive. For twins, the parity is 1, it is not 2. And the second cesarean section in 2020, and an alive baby boy was delivered, and he is alive. So she had 2 pregnancies, 1 set of twins, 1 singleton, and there are two babies alive, one girl, one boy. Now, this is her third pregnancy, and her LMP was 16th of May 23. She presented to us on for the first time on 19th of December at 31 weeks of gestation. And on examination, it was found that the fetus was in oblique position, oblique lie, and placenta was low. Previa ultrasound was carried out, and the report was that it's an anterior placenta previa type 4, and further that it is placenta increta. This is a common thing, but the important thing in this is the points that you would discuss with the couple about the further management and the counseling that you will carry out. And the important thing is that that counseling, I'll just give you one tip for that, that the counseling should not overwhelmingly be frightening. It should not scare the patient, because most of the times what happens is that when you tell that this is a serious condition, you'll need so many blood transfusions, and the uterus will probably will be needed to be removed, and you can have injury of the bladder, ureters, intestines, and so on and so forth. So one scares the patient. Now, the same thing can be said in a kind of different manner, in the sense that it does not evoke that scare, or it doesn't frighten the patient in that fashion. And that is that, yes, this is something which is now quite common. This happens, and this is a result of repeat cesarean sections. This is a potentially serious issue, but we need to take precautions. We deal with such patients. We can deal with that, and we need to have preparation for this. And for preparation, because this is a situation where excessive blood loss is anticipated, and therefore we need to have a large number of cross-matched blood available at comparatively short time. It is good that we have diagnosed it at this time, when we have sufficient time to arrange for that. So unfortunately, in our blood bank system, we do not have blood available like that, and you need to have you need to arrange so many donors. So you do that, and then when would that be, or when would that be required? It ought to be fresh blood, etc. And well, and of course, you can also say that because of the nature of the problem, we might need to involve surgical colleagues in this. And obviously, because of the nature of the procedure, the hospital stay would be a little longer, and there may need to be a need for a second surgery. So that kind of thing, if you say it in kind of mild manner and in the way of explaining things, then the patient, because I remember yesterday when I was telling them all, and after I had told them all, the couple, the woman went off smiling. She was smiling when she left, instead of being frightened and all that. So that is the important thing that I would want to. And of course, build up her hemoglobin. Her hemoglobin was already 10.6, which is rather low, because our aim these days is that we should not have a woman reaching term with less than 11 grams hemoglobin. And if it is, then now we have injectable iron available, which can be given at this time at 31, 32 weeks. This is a good time to assess hemoglobin and then prepare the women, even in a normal pregnancy, straightforward, in which normal vaginal delivery is expected, that you take care and you take care of that. And, you give injectables if there is poor compliance, or even at this time, if she starts taking iron, or there must have been some reason that she hasn't taken iron so far, or haven't worked it so well. So therefore, there is a strong case for intravenous infusion of iron injections at this time. So we give that to build up her hemoglobin. She already had probably a couple of injections, so she was advised a couple of injections more, so that her own hemoglobin is in good range. Okay. Right, this is another patient, Miss Alia Has, whatever, whatever. She presented in 2020 at the age of 28 years. And she had an ultrasound, and it was an incidental finding of a large fibroid. At that time, the fibroid was 9 into 9 centimeters subserous, and there was no definite internal vascularity. That's the scan of September 20. In February 23, she came, and it was found that initially the uterus was not palpable, and now we found out that the uterus is 18 to 20 weeks size. And she was advised at that time, she wasn't married, and now she is 31 years. And she was advised myomectomy about 6 months before marriage. But she was reluctant in having surgery for that. She is again presented now, and fibroid size is 10 into 9 into 10 centimeter, displacing uterus and lower endometrial cavity towards right side. So this is, and then there is another fibroid which is comparatively smaller, but this is the main fibroid. And she is planning to have to get married in about 6 months' time. So how would you proceed? How would you counsel her? What will you discuss? She doesn't have any menstrual symptoms. She doesn't have any pressure symptoms. So she is asymptomatic even now when the fibroid is, the uterus is about 18, 20 week size. But this is up for decision, that should she have myomectomy before marriage? Should she have marriage and then try for conception for some time? And if she gets pregnant, and she had to have advised to have to complete her family and then go for whatever myomectomy or hysterectomy. So this is the kind of, and she is a very well educated person. So therefore, if the discussion has to be educated, and one of my comments for this particularly for in such cases is, although the book does say that when you discuss myomectomy with a woman, you should talk about the possibility of removal of the uterus, that if it comes to that, the situation kind of develops into this level that what is going to be left is going to be a useless organ, not really good enough for reproduction. So why not remove that? But discussing removal of the uterus in an unmarried or a recently married woman, or a woman who has presented with infertility while removing or when advising her myomectomy, is something that I will not do. I won't. Even in milder terms. In last 40 years, I have had only one occasion when I had to remove uterus. Fibroid is very common, and that is the only type of fibroid that I saw, because it was what you could call it. I haven't read that term anywhere, but I would call it a miliary fibroids, miliary fibroidosis type of thing, because these were small bunches of fibroids which had studied the whole of the uterus. They were subserous, intramural, and so it was a large bunch of small fibroids. The uterus had been replaced into that, and there was no way, just no way, that one could have removed 1 or 2 or 3 or more bunches of those fibroids and leave behind the uterus. So therefore, during the surgery, then I had to call her husband, and then I explained to him that this is what it is, and then I did hysterectomy. So in more than 40 years of my practice, I've done only one. Therefore, I would be quite hesitant in a woman who is at this stage in her 30s, even early 30s, for her to be advised. So therefore, you have to choose your words and phraseology very carefully when you talk about that. And uh, if, say, in the examination situation, the examiner asks you that you haven't discussed with the woman the possibility of removal of the uterus at the time of surgery, then you can say that the occasion for that arises seldom. And most of the gynecologists haven't done in their careers any hysterectomy which was not planned already, or which only at the time of surgery in case of fibroids is required. So there is possibility, but that is very remote, and it will be rather unkind for me to discuss that kind of eventuality with the patient at this stage. And in a woman who is seeking pregnancy or who's getting married and all that, or and considering this situation. So I will, if I am the examiner, I'll accept that approach. So, but this is what it is, what was required in this. All right. This is a girl who's 22 years of age. She came in May 23. She is studying in London and doing her master's. And she presented at that time with the delayed cycles or prolonged cycle, acne and hirsutism. Ultrasound showed polycystic appearance of the ovaries. So management. It is simple. Polycystic ovaries are so common, and one may think that this is not something that even one would practice discussing, but this is some of the common things sometimes get you on the wrong foot and can cause confusion. But this is a comparatively, I would say, this is a comparatively simple situation because there is diagnosis of polycystic ovaries on two of those three Rotterdam criteria, which is that there is morphological appearance of polycystic ovaries on ultrasound, and she has the metabolic, not metabolic, but because her weight is at that time was 112, 123 pounds. And yesterday when she came, her weight had come down to actually 112 pounds. But she had facial hair and she complained of acne, and her periods were a little delayed. So that is it. What would you prescribe to her? How would you counsel her? How would you explain to her? And because some of these girls who are studying and who have read and who have, these days Google is there and they have read usually something about the topic. And another thing is that most of the women who are a little educated, they become afraid of hormones. I don't know where they learn that from. And my general approach for them is to tell them that you normally have hormones in your body produces hormones, but what your body is now doing is that it is producing hormones in an irregular fashion. So when we give you hormones, we give you the same hormones that your body produces, but when we give them, the objective is to regulate the delivery of hormones to your system, and in that way regularizing your menstrual cycle and also making up for any deficiencies, or to address some of the increased level of hormones which are causing some of those features and symptoms. And so there needs to be an explanation for their questions and the women's concerns about this. So in this patient, because of her irregular cycle, because of the hair, and because of acne, and again, she is also likely to get married in 6 to 8 months' time, I prescribed to her Dian 35, which is ethinyl estradiol 0.335 milligrams which is the 35 micrograms, and it also has cyproterone acetate, 2 milligrams. Small dose, but this is quite effective if it is given for 6 to 8 months. In most of the girls, this does address the issue of hirsutism, and I've seen virtual beards disappearing in about year's time. So this is it. I would give her Diane and Diane for 6 to 8 months till she gets married and all that. So because that will counteract those androgenic symptoms of hair fall, appearance of facial hair, and acne. So this is the treatment for this girl at this stage. This is interesting, not a clinical problem for the practicing doctor, but a woman who is 42 years of age, married in 2017. She had 4 failed ICSI treatments. And the last frozen embryo transfer treatment was carried out in September 23. But she didn't have pregnancy, 42 years of age. Then she had her periods on 30th of October. And in December, her pregnancy test became positive, spontaneous pregnancy. She has multiple fibroids. And on 19th of December, on 23rd of December, ultrasound showed an 8 weeks and 2 days pregnancy. Regular gestational sac, multiple fibroids noted, posterior wall 52 into 40, left lateral wall fibroid 43 into 40 millimeter, and another one 24 into 21 millimeter, right lateral wall fibroid 67 into 51 millimeter. And she is obviously, because of her history, and she is concerned about what are the possible problems of the pregnancy because of her age. What are the possible problems she can have because of the presence of fibroids? And what are the different problems that the fibroids can undergo because of the pregnancy? And how would she fare through this? These are the questions. Anyone from you who would want to comment on this?
So for fibroids, pain in pregnancy, red degeneration of fibroids. What's the age-related pregnancy risk factors?
Good.
42
So there are essentially this is so to say the precious pregnancy one, and then age-related issues. So you have to be careful about that and not alarming the woman, but then you have to advise her to go through that those checks, etc., and tests to identify any issues which can be there, because now we have anti-scans, we have other means of identifying some of the issues which are related, for example, Down syndrome, etc. So if NT is done at 12 weeks or 13 weeks, between that window of 11 weeks and 13 weeks and 5 days, and if it is charted according to the given range of normal NT, then one can be assured about that. And if there is any doubt still, then the couple can go for harmony test, and harmony test is quite good enough. Now, this also brings me to a question. Recently, I had a patient only, this week, day before yesterday, she came back. She had previous 3 cesarean sections, and now she has a twin pregnancy, and she is at 14 weeks. She had ultrasound 3 days back, and and she is 42 years of age. She is also 42 years age. The patient that I'm talking about. And one of the twins has one twin has an NT of 1.5 millimeters, and the other twin has an NT of 3 millimeters. She is 42, and the significance of that 3 millimeters NT. And then she was there were two ultrasounds, one in Saudi Arabia and one in Pakistan, which showed that there was some irregularity of part of the uterine wall, and both had commented that there is a possibility that it could be uh, an invasive mole area or something like looking like a mole. So the no, sorry, I am confusing that with another. Yeah, this is the patient. This is the patient in whom it is like that. So how would you go about it? ये आप मुझे अपना बताना, मैं नहीं अभी आपको बता रहा कि क्या है. This is the one who was. We had a patient yesterday, second gravida, whose EDD was 7th of January 24. She came to the clinic yesterday for her routine antenatal, and I thought, since why not induce her or something? So the regular practice of sweeping the membranes, and Dr. Aisha did her pelvic, and she said she is 4 to 5 centimeters. So we sent her to the labor room for observation that we'll induce her in the morning. And half an hour later, there was a frantic call that she is about to deliver. And we saw her at about 5:40, and at 6:30 she delivered.
Yeah.
Spontaneously. So.
She barely had a
Oh. Right. This is a woman 33 years old. Actually, I'd say couple who presented yesterday, married in November 2020, and gave history of one miscarriage in February 21 of 5 weeks, medically terminated. Secondary infertility, husband 32 years, and the report is azoospermia on semen report. And in one ART center, TISA was carried out, and a few sperms were found. The report was that 1% were normal, but 100% were immotile. What would you do? Male infertility factor. The report is, and I'll tell you, I did examine the patient. I don't know whether you have this in mind or not, that the male patient also has to be examined, particularly of azoospermia. And I found that testicular volume was rather more than normal. My impression was, which is an important factor. So if a couple presents with male factor infertility, and the husband's semen analysis shows azoospermia, what do you do? First, you examine the patient, examine the husband, and then if the testicular volume is normal, then what do you do? If the testicular volume is low, then what do you do? What hormones would you want to assess? What andrological workup of the man should be carried out. And I don't do that, but we have a very good andrologist colleague who does also vasography and identifies whether there is blockage of that. And also testicular biopsy is out, that should not be carried out, but epididymal sperm aspiration is something which is like TISA was carried out in this man. That is the possibility, but I'll let you know in about a year's time about this patient, what became of it, if they continue to come. This was the first visit, but I haven't, after examining, I advised them to have FSH level to see, and I expect FSH level to be normal in this man. I'd be very surprised if it is low, or if it's too high, as a matter of fact, too high. If in those cases where the testes are small in volume, they're shrunken because of late descent or whatever, or lack of development. In those cases, the FSH level is high, and that's what is to be expected. And if the FSH level is high, then the prognosis is poor. And so far, if something comes out of stem cells in 5 to 10 years time, that's a different thing. But then you advise them, not in our country, but it happens in Iran or in other countries. You need to inform them that there is ART through donor semen, or even IUI through donor semen, if that would be acceptable to them, and that must be confidential and all that. Scientifically speaking, we need to discuss that. And as in one of the Muslim countries, this is something which is being practiced, or the couple may even request that we would want to go for that, then that is something that can be advised. So our own religious belief should not come in way of advising or informing the patient of the possible treatments which are available here or elsewhere. We may not do it ourselves. Some of us may not be willing to terminate a pregnancy. But it is obligatory on all of us as professionals to direct the woman, not being judgmental, to direct the woman where she can procure or obtain a safe abortion, for example. This is called value clarification situation, in which we need to look at those things objectively, sometimes objectively, and putting our own selves into that situation, that what will happen if that happens to us. So as I said, it's important that you go according to your own religious beliefs, so far as your own practice is concerned. But professionally, what is required of us is to advise them of all the possibilities which are available. Another girl who came complaining of seeking conception, because I wouldn't label her as infertile, because she was married in November 22 and she came to us in May 23 seeking conception. We were living together. The woman's history was of anxiety, panic attacks, and she, although 21, but she gave history of raised blood pressure, and she was on SSRIs, alprazolam, and also on Inderal, and also on Praxil. So these were the medicines that she was taking, and she was planning a pregnancy. So the question is, what about her psychiatric issue, and whether she continues with these drugs while she plans to have pregnancy, or she stops them? So what would you do? कौन सी?
वो जो ले रही थी सेफ थी सर,
Hmm?
जैसे प्योर प्रेगनेंसी सेफ
हाँ वही बात है ना कि ये
SSRIs और वो ले
हाँ
20
अब तो
मिलीग्राम तक से।
अब तो ये कल तो 36 वीक्स प्रेग्नेंट थी ये
अच्छा ये और है।
हाँ ये और है ये तो है इस तरह but
And if they were pregnancy safe, then she should continue that.
she should continue you reassure. You see, whenever you talk about these issues, it is important to tell that there is a background chance of major abnormalities of about 5%. And major abnormalities of central nervous system of about 2%. That is the most common. The second most common is cardiovascular system abnormalities and then the other abnormalities. So that is the background chance without any treatment, without any medication, etc. or whatever. So if even if those medicines are generally said to be safe and they can be taken during pregnancy, but if something happens that would be from amongst those issues. In fact, just genetic. Okay, another I am going to give you an issue. You know, since 1st of January, what we are doing is that we are putting the patients in various categories. I told you that probably. So we are going to have them in those categories, and at the end of the year, so we have list of our PCO patients, list of our endometrial hyperplasia patients, and then we can look at them and publish
This is the
papers.
basis of a very good research
Huh?
already.
Huh?
Very good basis of a research
Yeah.
already.
So since yesterday we started making that list, and this year we are going to have that. Preterm labor है, recurrent miscarriage है, ये वाला ये इतने सारे recurrent miscarriage के इतने सारे हो गए, polycystic ovaries हो गई, ये तो काफी सारे हैं. So एक genetic वाला issue था, मैं वो निकालना चाह रहा था.
Do you have all your old cards as well?
अब वो उसमें से आते जाएंगे तो देखते जाएंगे हम.
नहीं इसमें incorporate करने ये करना है. बहुत बड़ा data.
A patient, yeah, she is, all right, I remember his history. She is 31 years of age, and she has one first pregnancy resulted in birth of a daughter, and she is well and healthy. After that, she has had 4 mishaps in all pregnancies. They were either terminated or their expulsions took place around 20th in second trimester, second trimester, and all of them showed structural abnormalities. Those fetuses, which were either expelled or which were, and the pregnancies were terminated because abnormalities were found on ultrasound. Now, how do you advise? And she said so because you see, many years I remember I many times quote from Jeff Gurt wording 1974 edition. I've said about that so many times that in cases of repeated abortions, the woman, because those authors they used to kind of tell about the situation, that those women are in a very sorry state of affairs in the sense that they want to get pregnant, but they are afraid to get pregnant. They want to have a child, they yearn for a child, they long for a child, but they they are afraid to have a pregnancy, and therefore they need special care, special attention, special reassurance which is substantial, which is substantial. You can build upon that. And fortunately now we have some of the genetic tests which are available which can identify. But the question is whether you test genetically the husband or the wife, or you carry out the genetic testing of if there is pregnancy or there is the birth of the baby, of that baby, to find out abnormalities. Now, she is not pregnant now at this time, and then these tests are not cheap, they are expensive. For an average patient, they are expensive, but some of them they are available. and therefore you need to look up about the various screening tests. First, there are screening tests for fecal abnormalities. There are screening tests, for example, now for preeclampsia. There are screening tests for others, screening tests for diabetes. Though, and similarly, there are screening tests for fetal abnormalities. NT scan is one. Then Harmony is another one. Amniocentesis is another one by which you can. Amniocentesis is something which will give you 100% that outcome or the result. But then the possibility of, or if you want to, genetics is now an emerging field, which is important. And now we have uh, doctors and others who are specializing in that, and we need to take advantage of their expertise. So therefore, those tests are available, even if not here, abroad, where the samples can be sent and then assessment can be carried out, so that one can make some reasonable inference from that, that yes, this is the chance that you have 50% chance, 25% chance of developing this. And when you get pregnant, then these tests will be available, whereby we will identify at an early stage what is happening and whether this pregnancy should be allowed to continue, or then in case there is a problem, then the pregnancy, then we should offer termination. So this is about it, and here we are at 9:30. Assalamu alaikum ji.
Good morning, sir.
Alright.
How are you?
ठीक ठाक।
भाई टाई लगा के ते गुड मॉर्निंग कर देने, मेरे वंगट बगैर टाई तो अस्सलाम वालेकुम कर दे, इतने उल्ट हो गया।
उल्ट हो गया, हाँ। आज की पढ़ाना है जी?
मैं एशरमैन सिंड्रोम।
अच्छा।
जो मैं ते अपने वालों पढ़ाया सी सेकेंडरी मिनोरिया दे विच पर 2-3 दफा इनकी तरफ से रिक्वेस्ट आई कि जी एशरमैन पढ़ाए। एशरमैन नु खिंचना 1 घंटा जरा कम है।
एशरमैन essentially 5 minutes फिर मैं अगर बोलिया तो तुसी कहना तो मोहम्मद भट्ट दा भाई याद आ जाना।
नहीं
Actually, I think
क्या लग गया सी कहना।
Escherman is, if it is diagnosed, particularly nowadays because of hysteroscopy, the diagnosis one does, and advances in ultrasound and hysteroscopy. Our ultrasonologist Aisha Umar, she can suggest that there is a possibility of endometrial adhesions and synecdoche, etc. And then obviously there will be history and then presentation and then ultrasound and then hysteroscopy, which is diagnostic as well as one can carry out assessment of the uterine cavity as such, and if needed.
एक मिनट रुकिए। फर्रुख साहब ने सारा एशरमैन एक फिक्रे में पढ़ाया आपको। अगर आप इस एक फिक्रे को याद रखेंगे तो एशरमैन आपको आ गया। इन्होंने बोला है हिस्ट्री, फिजिकल एग्जामिनेशन, अल्ट्रासाउंड एंड हिस्ट्रोस्कोप, ये बोला है, इस ऑर्डर में बोला। तो अगर आप इस ऑर्डर में यही 4 अल्फाज याद रखेंगे तो आपको एशरमैन का केस वो टोक्स पे केसी स्टेशन पे आएगा, नो प्रॉब्लम। आपके 7-8 मिनट एलोकेटेड होंगे, आप 5-6 मिनट में उसको पूरा कर लें एंड गेट फुल मार्क्स फॉर इट। क्यों फर्क?
जी बिल्कुल, वही वाली बात है कि ये इसमें ये जो डायग्नोसिस है उसमें हिस्ट्री काफी सजेस्टिव होती। ऑब्वियसली देयर विल बी दैट काइंड ऑफ हिस्ट्री। फिर आप जो एग्जामिनेशन पे आजकल most of the as a matter of fact we are become so used to this that one would imagine that in every OPD or in every clinic, there would be facility for the gynecologist himself or themselves to carry out an ultrasound and see actually where the uterus is, the position of the uterus, what is the size of the uterus, and a good ultrasound machine would also, it is not difficult to find out the endometrial lining. So you can see the endometrial lining in many cases if the bladder is adequately filled, etc. And then, of course, ultrasound gives a good indication of what it is. And if you suggested, if you made a provisional diagnosis on the basis of history and the ultrasoundologist looks at that. So,
Actually, कि फिजिकल एग्जामिनेशन में जनरल फिजिकल एग्जामिनेशन के बाद पेल्विक एग्जामिनेशन और अल्ट्रासाउंड मेरे नजर में तो ऑलमोस्ट सिनोनिमस हो गए हैं.
Actually, now there is debate about that or discussion about this, whether a pelvic examination, a digital pelvic examination is required until and unless there are symptoms which are suggestive that it should be carried out. For example, if there is pelvic pain or dyspareunia or vaginal discharge or something like that, which would warrant a speculum examination or a digital or bimanual examination. If there is no such complaint, then one could go on with an ultrasound and have a good assessment. So,
हेल्थ प्रोफाइल और सीबीसी हीमोग्लोबिन उसके अल्ट्रासाउंड के बाद आ गया.
हाँ बिल्कुल बिल्कुल उसके बाद आ गई. ठीक है.
हमने कहा कि क्लिनिक में अल्ट्रासाउंड ऑलमोस्ट सेम एज डूइंग पेल्विक एग्जामिनेशन.
बिल्कुल बिल्कुल
हर अच्छे गायनेकोलॉजिस्ट के पास अल्ट्रासाउंड है उसके क्लिनिक में. वेरी स्पेशलाइज्ड अल्ट्रासाउंड एग्जामिनेशन के लिए वो सोनोग्राफर के पास भेजते हैं. अदरवाइज जैसे पेल्विक एग्जामिनेशन करना है वैसे ही वो टीवीएस या एब्डोमिनल साउंड के साथ कर लेते हैं.
Even in obstetrics, routine obstetrics, it is so helpful because you see, when you, no matter how experienced, I still try to palpate the abdomen first before I place the ultrasound transducer on the abdomen. I try to still that what is the presentation and where the back of the baby is, and to have some assessment of the amount of liquor. But quite a few times I come out wrong. I thought that the back of the fetus is on left side, but when I put the ultrasound transducer on that, I find it that it is on right side. So it is in 10 seconds, it gives you so much of information. You put on the lower pole of the lower abdomen, tells you about whether there is head or not. On one side, you can find the back, or you can find the liquor and placenta, and on right side, left side, and there you are. So with greater accuracy and better information.
Thank
Thank you, sir.
you.